morning. On behalf of the Planning Committee, I want to welcome you to the 2019 Academy Health Annual Research Meeting. So I'm so excited to spend the next 3 days with over 3,000 amazing colleagues dedicated to improving health, healthcare, and policy. Over 3,000 of you, that is a new record for Academy Health. So before we move into the heart of the plenary session, I'd like to start by telling you a story. And it's a story about why I became a health services researcher. It was when I was just starting my second year of residency in internal medicine. My medical center decided it could no longer afford to accept new Medicaid patients in primary care clinics. So when I was on the wards taking care of patients with AIDS, with heart failure, with diabetes, I could not refer those patients when they were discharged to my primary care clinic or to any primary care clinic in my hospital. The only place I could send them for follow-up after discharge was to the emergency room of a nearby public hospital. Well, this made me really angry. I complained every day on rounds, so much so that my attending finally told me, "Eve, stop complaining. Do a study, figure out what happens to these patients, and try to make a difference." My attending was a health services researcher, and he helped me, a second-year resident, design and fund a study. He helped me see that we needed data to try to make a difference. And while I was trying to carry out this study, in between call nights and long days in the ICU, I learned another thing about health services research. I learned that health services research is a team sport. I couldn't do the study without the phenomenal Spanish-speaking research assistant, without the clinical champion who wanted to implement the results of the study, without a specialist in survey research who helped me develop valid outcome measures. I learned that we can't hope to make a difference unless we bring people together with diverse backgrounds, experience, perspectives, and roles, who design and carry out innovative studies and implement policies together. And for me, that is what Academy Health is about, and why I'm so delighted to chair the 2019 annual research meeting. Because ARM is all about you. Scientists and clinicians and patients and policymakers and managers and executives and journalists. Those of you who have been doing the business of healthcare for 2 years and for 20 years or more. You are the team that can make a difference for improving health and healthcare because you bring diverse perspectives and backgrounds together. So I'd like to spend just a few minutes to highlight our diversity at Academy Health. Right here at this meeting, we have representation from nearly every state in the country. And though it wouldn't fit on the slide, we also have representation from 10 other countries, including Canada, 5 countries in Europe, Korea, Taiwan, Japan, and Australia. And while the preponderance of our registrants hail from academia, you can see that a large proportion of registrants come from many, many different sectors. We're also diverse with respect to our gender, with about 60% of all members being women. And you can also see that our registrant, and importantly, our speaker gender diversity, tracks the gender diversity of our overall membership. We're also striving to do better with collecting more accurate data on all aspects of our diversity, including race and ethnicity, so that we may be able to present more information to you in the future. One of the things I'm really proud of in this year's ARM is that the Planning Committee made deliberate choices to focus on diversity. And while we didn't succeed in all the ways that we hoped, we think that we've made great strides and moved the needle in the right direction. And I really want to give a big shout out to the members of our Planning Committee, all of whom contributed an incredible amount to planning an exciting set of sessions that you are all about to take part in. I especially want to thank Dr. Reginald Tucker-Seeley, who's the vice chair of the Planning Committee, as well as AcademyHealth's fantastic staff, who truly, without them, this meeting would not be possible. I also want to thank all our supporters who helped make this meeting possible. And finally, I want to thank all of you for being here and for trying to make a difference. You know, something I've learned by observing the careers of so many of you is that if you want to make a difference, you have to be deliberate. Deliberate in your choices of what to study, who to include on your teams and on your panels, and how you implement findings into policy. So as we now kick off the annual meeting, I hope that all of us will think about how we can each be deliberate in making our meeting experience even more meaningful. Reach out to meet people you don't know. Go to a session that is out of your comfort zone. Help first-time attendees make new connections. Because by being deliberate, we can all make a difference.
Years ago, standing on this stage really seemed like a dream to me. Because you see many young boys grow up dreaming of becoming firemen. Some people dream of becoming a policeman. Others dream of becoming professional athletes or rock stars. Ladies and gentlemen, when I was a young person, I turned to my parents and said, "Mom and Dad, when I grow up, I want to be a health services researcher." And if you don't believe me, I dug into my archives and found some proof, which was my medical school personal statement, where I wrote almost 20 years ago, "Hopefully, over time and working as an academic physician and policy researcher, I will have developed the knowledge to achieve my dream of designing and introducing effective policies at the state or federal levels of government." This was written in 2001, and yes, I was a nerd, I am a nerd, and I'm proud of it. Now, my life has taken lots of twists and turns since then, but I want to use my time with you this morning to reflect on lessons learned trying to create change through health policy, through health services research, and healthcare management over the last 2 decades. My very first college internship got started 20 years ago this week, actually, right here in DC in DuPont Circle, and it was at Alpha Center. Any of you remember the Alpha Center? Woohoo, Alpha Center. I've never seen so much pride for a small think tank that eventually actually became a part of Academy Health. And that summer, I worked for a remarkable woman, Deborah Cholet, who is a noted health economist. And I remember going to work every day with a simplistic operating model of how we create change through healthcare policy. I believe that acclaimed health services researchers like Deborah analyze policies and their effects and publish papers on them. And then policymakers and regulators would glean insights from those papers and effectuate changes in policy. It seemed clean, it seemed precise, and rational to my 19-year-old brain. They were producers of insights, they were consumers of insights, and they worked together to improve health. It was a mental model which made perfect sense to me, which was great, except for the fact that it was dead wrong. I learned over time that the straight line that I had imagined was actually a twisted tangle, where many insights that arose from policy, often policy research, oftentimes common sense observations, never actually make their way into practice. There were the usual methodological debates about whether the insights were valid or replicable. There were the challenges getting the attention of regulators or policymakers. And even if you got their attention and succeeded in navigating our complex world of healthcare politics, there might be a failure to uptake the new policy or regulations by the individuals or institutions that were actually responsible for implementing them. And then, of course, there were the unintended consequences when policies are implemented in the real world. Nowhere was this more apparent than in the early days of the Obama administration. There were so many whose work and insights failed to make their way into the implementation of the HITECH Act and the ACA. It might sound funny now, but my overly simplistic mental image before I worked at HHS was that there were legions of well-intentioned government employees like my friend Aman Bhandari at CMS. Any Aman fans out there? Woo! Whose job it was to read JAMA, HSR, Health Affairs, the New England Journal, and drive the insights that they gleaned from their reading into practice. And while there were a few instances of a straight line where the work of people like Larry Castellino and Julia Adler-Milstein clearly informed the design and implementation of policy, Larry's studies on the cost of implementing EMRs were used to quantify the meaningful use subsidies. Julia's work on the state of health information exchange shaped the administration's approach on HIEs. There were only after becoming one of those well-intentioned government officials a decade ago did I realize that in the complicated world of healthcare policy and healthcare politics, happenstance plays a far more important role than anyone would ever like to admit. Sometimes who you know might be just as important as what you know. The identity, the persuasiveness, and the credibility of the messenger of the evidence often matters as much as the evidence itself. Oh yes, and timing matters a lot. Of course, I'm not the first person to make this latter observation. The legendary political scientists Deborah Stone and John Kingdon both noted the importance of policy windows. Policy windows, you'll remember, are the brief moments in history when big, monumental pieces of legislation are passed, and when a large legion of homeless ideas find a home in legislation or regulation. And nowhere was this more evident than in the ACA, where long-heralded ideas of people in this room, like ACOs and bundled payments, finally found a place, and in finding a place, found life. For me, it was incredible. It was remarkable. It was even breathtaking at times to watch so many ideas brought to life and change catalyzed at scale. But as a young staffer in government, it raised a question for me about what I wanted to do at a time when I still thought my full-time career would be that of a health services researcher. Waiting for that generational window is a great strategy to create impact for the deeply committed, dedicated souls who are patient enough to wait for one. But what are those among us who are less patient to do in the face of these circumstances? For we could all write papers whose punchlines begin with policymakers should. How many of you have written a paper with policymakers should? I have, guilty as charged. But what if our politicians only open these windows every 10, 15, or 20 years? How will the work of this community still be relevant and drive the change we hope to see in the world? I fundamentally believe that the opportunity for health services researchers to drive impact is far greater, and the audience of interested parties is far wider than just policymakers and politicians. Now, my own way of resolving this question was to actually make a pivot and to go to work in the management of health systems where I believed I could make a more immediate impact. The move to management, however, hasn't been without its feelings of loss. So while my time in working in health services research highlighted a host of challenges that the field faces, much of what I love about health services research, methodological rigor, a high degree of creativity and originality, a passion for getting to the bottom of the hairy truth, is often very difficult to actually translate into management practice, no matter how badly it's needed. The very need to drive to conclusions in the face of imperfect information often trumps a more natural instinct towards careful study to arrive at the right answer. That said, I have a small, provocative, and potentially controversial proposal to make that I believe is worthy of your consideration. Now, a little-known fact about me is that I am a proud 5-time matchmaker. It's true, and if anyone wants to approach me after this, they can. I have 5 marriages to my name. Now, the skeptics among you will note that I've ignored sharing the denominator of the number of matches attempted. And I could say a lot about how matchmaking is actually a truly thankless art form. You get invited to the wedding and then they never call you again. But I'm here today to propose a 6th match, and that is the marriage of 2 tribes that I think for far too long have evolved separately. These tribes, of course, are the Health Services Research Tribe and the Healthcare Management Tribe. These tribes have operated independently of one another for far too long. And the time, frankly, has never been better for us to unite and to solve problems of both local and national importance. Now, most healthcare organizations, health plans, healthcare delivery organizations, don't have an R&D function. And bizarrely, departments of health services research are almost always disconnected from the operations of the organizations in which we work. And I believe that this represents a missed opportunity and a divide that we should aspire to close. Now, I can't claim to fully understand the origins of the disconnect. Perhaps it lies in how we were trained, or a natural separation based on our interests, or a difference in the reward systems that exist across fields. But as someone who's spent time in government, in academia, and now leading an organization that delivers care, I have a strong conviction that the work of the people in this room has the opportunity to drive, shape, and inform evidence-based, data-driven management decisions that can meaningfully improve the health of the communities in which we work and live. Now, I'll tell you that it won't be immediately easy. There are differences in language and communication between the research and management tribes, differences in values and priorities, concepts that everyone in this room takes for granted as part of a first-year statistics course, the basic experimental design, the idea that correlation and causation are not the same thing will need explanation and translation. You'll need to change how you communicate so that your insights are properly understood. But if you can do this, if you can commit to this, I believe that we will catalyze and accelerate change in healthcare delivery in ways that we never have before. Because those of us who are trying to change healthcare delivery from within, we need your insights. We need your help understanding what does and doesn't work. We need your help developing methodologies for identifying who our sickest patients are and where we should target our efforts. We need your help understanding how best to structure and organize healthcare delivery systems to achieve the kinds of outcomes that we want to. We need guidance that is both locally relevant, that broader evaluations and broader studies don't actually capture. At CareMore, the healthcare delivery organization that I lead, we've been focused on building internal research capabilities and partnering with external researchers to glean insights on the effectiveness of longstanding programs, but also test new ideas in practice. The value of these partnerships is immense. We have innovative programs in social determinants of health, on transportation, and converting people from analog insulins to human insulins. And the results of these studies and these evaluations that we're undertaking with research partners help inform our strategy and capital allocation decisions and decide what initiatives we should scale and which ones we should shut down. Our research partners take time to understand our organization, and in doing so, ask unexpected questions that force us to think about how programs are designed and implemented. And we've gleaned valuable lessons that we've published for others to consider in their own contexts. Now, I'm certain that there are those among you who will bristle at the notion of focusing your efforts on a single institution's problems when you're used to thinking on a much grander scale. To which I would say, just try it. You might just find it uniquely rewarding. Challenge yourself to be in a position of local relevance, even as you drive towards influencing a national conversation. We all know this very funny caricature of individuals whose work is nationally famous, but locally unknown or irrelevant. Anyone ever feel this way? Right? This is not a unique feeling. Let's work hard to change this paradigm. Challenge yourself to be in a position of local relevance, even as you drive towards influencing a national conversation. The work of changing health systems is hard and complex and political and too fraught with consensus-driven decision-making in areas where it is clear what needs to be done. We all know these areas. You can be the voice of conscience and help science and data inform our moral imperatives. Call it delivery science, implementation science, the learning health system, health services research. What we call it doesn't really matter. What is clear is that we continue to have a crisis of healthcare in this country, and we need to bring forth new ways of working together to make things better. To be clear, I'm not underestimating the challenge or the obstacles inherent to what I've proposed. Every marriage has its challenges, as many of you will attest. It is these challenges that actually drive the greatest growth. And I can say with confidence that this field and profession is ripe for the next stage of growth that can be catalyzed by reimagining your audience and the partners with whom you align. And every one of us knows what needs to be done. Now it's time to go do it. This is not a new idea. These two tribes have been dating on and off for years. But it's time to get married. So in closing, as Queen Beyoncé told us, if you like it, you should have put a ring on it. If you close the deal, you'll leave an even greater impact on our healthcare system than you already are. Thank you very much. What's that? Yeah. She said this.
So, right. So I'll invite you to sit next to the box on the left if you're a member of the Bay Hive. So, no one needs an introduction for our next keynote speaker. Dr. Lisa Simpson is in her 9th year as the president and CEO of AcademyHealth. And because this is a session on the rock stars of HSR, I think it is worth reminding ourselves that Dr. Simpson is in fact a rock star within HSR. She's a nationally recognized health policy researcher, a pediatrician, as well as a passionate advocate for the translation of research into policy and practice. She's also a passionate advocate for the diversity of voice and perspective and for the future of HSR, and really is someone who focuses on the impact and the role of evidence and what it can do to really help drive and improve healthcare in the United States. So please join me in welcoming Dr. Lisa Simpson to the stage.
Thank you, Sachin. I don't have any Beyonce slides or great quotes, so, but that was terrific. Thank you. So, as always, it is a terrific pleasure to take the stage and to speak to you and this vibrant and diverse community that we heard about from Eve of health services research producers and users as your president and CEO. Today, Sachin and I are reflecting on the future, but we've also been reflecting on the past. So I too have a story to start with. So this is me, almost exactly, actually last week, 18 years ago, right before the birth of our twins. So, you know, it's a pretty standard pose for most big-bellied women. Sideways, smiling, a little nervous, about to go for my C-section, but really, you know, just joyful about the day arriving. But what you may not notice in this picture is that I'm wearing a wig. Why? Because I was 6 months into my breast cancer journey. You do not see on my face the toll of the hours of research and discussion with my doctors that ultimately helped inform some of the most difficult decisions of my life. Because when I was diagnosed, I was 11 weeks pregnant, so there were actually 3 lives on the line and no clearly good options. 1, I could wait and risk more advanced cancer, treating it until, you know, after my twins were born. 2, I could have surgery and chemotherapy in the 2nd trimester and therefore follow the existing clinical guidelines and risk potentially harming my babies because the evidence base was not as strong as I wanted. Or 3, and most difficult for my husband Richard, who's here today, and I to contemplate, I could terminate this long-awaited pregnancy so that we could pursue aggressive treatment immediately. An option I still had open to me then. Now, before we get too far, let me jump ahead and tell you that this story has a really happy ending. Not only am I here, but my twins have just graduated from high school. So why did I start my remarks here? Because my family story and our happy conclusion, or step in the continued evolution of our lives, was really the real-world impact of good work that had come before, of supportive health policies, and of sustained investments in research that together ensured I had access to all my treatment options and access to an evidence base to inform my choice. So many patients and families are not so fortunate due to systemic issues and structural biases, and thus the health system and we continue to fail them. Addressing those failures is why I do the work that I do. And when you think about health services research and why we collectively do what we do, I think it is because we want to inform critical decisions just like the one I was facing, whether those decisions affect one person, one family, a community, or a whole population. So as I look ahead to our future impact, I do so grounded by my training in pediatrics and health services research, as well as my experience as a patient. So that raises the question that you've been hearing a lot about at this morning's plenary: what will be our impact? Health services research will and must inform and support policies and decisions at every level to equitably confer on every person the options and advantages that I had 18 years ago, to patients, to communities, and policymakers, now and in the future. But realizing this promise will not be easy, I know, and requires that we commit and continually recommit ourselves to mastering some tried and true strategies for impact while also adapting to the current opportunities and, yes, challenges in our environment. So we must make sure that our research matters. We must remember that timing is everything. You've heard about that already. We've also got to learn to play the long game and build collaborations and networks. So making sure our research matters means doing what we've always done really well, gathering and assessing data to understand the scope of the problem and why it's occurring, looking for patterns and exceptions to the norm, and then acting on our ideas in search of a better way of doing things. In a small way, that's what I was doing as I was living my chosen profession when confronting my choice. Making our research matter, however, also means working with decision makers even more to ensure that the questions that we are asking matter to the problems they need to solve. It means continuing to look closely and intentionally for the intersection of our intellectual curiosity and their needs. Now, Terry Tennillian and her colleagues received the 2011 Hsr Impact that you just saw presented earlier to two amazing folks. But she won it in 2011 for doing just that. Responding to rising concerns over combat-related stress and the demand for change, their research helped put numbers on our growing awareness of the prevalence of PTSD, depression, and traumatic brain injury among our servicemen and women. And this resulted in policy changes that included mandatory screening and security clearance modifications. Their research mattered, and it made an impact. Their work was also timely, which leads me to make the same point that Sachin made, that timing, it's an old adage, timing is everything. And it's certainly taught in policy courses that many of us have taken. But until you actually live it, I don't think you really understand the depth of that lesson. And certainly timing was everything during my pregnancy because treatment had to be carried out in the second trimester, if at all. Now, Sachin talked a little bit about the Affordable Care Act. The 2015 Supreme Court decision in King v. Burwell is one of the highest profile cases in our field and health policy in recent history. So in early 2015, a team of researchers at the Urban Institute responded to the coming hearings and developed 4 issue briefs that outlined the implications if there was a finding for the plaintiffs. Not only were their findings and analyses cited in the administration's argument and the 18 amicus brief, they were noted prominently in the majority opinion. Their timing really mattered, and their research had an impact. But let's be honest, and Sachin said this as well, not everybody wants to or should play in the rough and tumble game of policy opportunities. For some, it is more rewarding to know that your research will build a body of knowledge that will be used in the future. And health services research, I truly believe we need both kinds. Ours is a big and diverse field, and to ensure that our research matters more and more, for us to have a sustained impact, we need researchers of all kinds who are driven by different passions. The future impact of health services research will therefore require that we incentivize and reward researchers who make careers either by quickly assessing what is known and informing policymaker decisions, but also for those who continue to steadily build the evidence base for the future and long-term studies. Sometimes you have to play the long game in health services research and build that evidence base, just like the evidence base I consulted when I was looking at my treatment options. Such was the case with research on the Child Health Insurance Program, and this is a story which I am proud to say I personally played a very small role in. So when CHIP was passed initially in 1997, it had a sunset clause that it would expire in 10 years. That gave the research and funding community a clear deadline for when evidence of CHIP's impact would be needed. To get that evidence, I forged a partnership with the Packard Foundation and HRSA, and together with an earmark that we got into the ARC budget, we launched the Child Health Research Insurance Initiative, or CHIRI, led by my colleague Cindy Brock. So hope you're out there, Cindy, thank you. It was terrific. And boy, 10 years later, we were ready. We had the evidence that policymakers needed on access, on quality, on disparities, on outcomes. Now, the political world was not quite as ready as we were. It took over 2 years and, yes, a change of president for the CHIP program to be reauthorized. But we played the long game in timing. We steadily built that evidence base. Our research had an impact. But of course, that work would not have been possible without important collaboration and networks. My cancer history, in one level, illustrates how networks matter. I'm not an oncologist. I've never studied oncology policy or treatment. But my professional network helped connect me to researchers and other experts who could explain and translate what I couldn't. It also forced me to seek out those going through similar challenges to speak up and advocate for my needs. I believe that health services research will have the greatest future impact if we can focus on what I believe is our field's greatest asset, and Eve alluded to this, the diversity of thought and disciplines that our field encompasses. Leveraging that diversity and cultivating networks of expertise and influence is what we need to keep making our research matter. Now, those 4 evidence-based strategies are well known to most of us, but before you pat yourself on the back too much, saying, oh, check, I knew those, we have to step back and acknowledge that knowing these and actually using them is only a necessary but not sufficient means to achieve the impact we seek in tomorrow's world. We are seeing unprecedented disruption in how facts, evidence, and data are created, challenged, or believed. I think our community needs to wrestle head-on with these challenges, or else we risk becoming irrelevant. Yep, irrelevant. So we must adapt to the future and capitalize on the technology and data transformation, navigate an increasingly polarized and fragmented public discourse, and be prepared for disruption everywhere, including the current academic paradigm. The technology and data transformation we are experiencing with its exploding computing power and avalanche of data.
Mike?
Yeah, I'm back. It provides us with the opportunity to pursue questions that heretofore we really couldn't answer, and to do those in even more timely ways for different audiences, including the audience Sachin is challenging us to marry. But this proliferation of data and technology also means that policymakers can find a fact almost any position, can find a fact to justify almost any position in the time it takes to Google, or patients can find expert advice from a host of individuals who are anything but that. And such symbolic use of evidence in policy is certainly not new, and we all know the power of a well-told anecdote. But I think the scale and scope of the challenge is far greater today. Throw all that together, and then you add the fragmentation of the public square into echo chambers informed by different sets of facts, and we have a burning platform for change. This means that we can no longer sit on the sidelines and be content with securing our next grant, next contract, or adding another peer-reviewed publication to our resume. Collectively and individually, I believe we have the added responsibility of speaking up for science and evidence whenever we can, with everyone we know and in every setting. Now, I will acknowledge that getting grants and contracts is not actually easy these days. A 2018 report on the next generation of biomedical and behavioral sciences research from the National Academy of Sciences warned of an academic enterprise that is calcifying. Their words, not mine. And among the red flags that they cite is the percentage of PhDs who are gaining a tenure track in 6 years has gone down from 55% to only 18% over the last 40 years. They also note that the average age of the first NIH R01 increased to 43 years in 2016. So not surprisingly, folks are seeking employment and careers elsewhere and pursuing a range of fulfilling opportunities in the private sector, such as embedded researchers in health systems, as Sachin is working on, and also working in contract research organizations. However, this trend raises the question of whether they're actually prepared for this new work environment, where a focus on impact is part of the value proposition. Do they have the skills that they may not have been taught in traditional academic settings? But folks who know me know I'm an optimist, and so I have to say, I think I can say this now that Game of Thrones is over, right? That all is not bleak winter, okay? Research funders, I am happy to say, are increasingly requiring a focus on impact, and several academic institutions are updating their promotion and tenure guidelines to recognize the effort that goes into translating research into policy and practice. Academy Health is focused on this future as well. We are trying to plant the seeds for a collective future with high impact. We are considering ways to help lead the field in responding to these new challenges and to preparing our community of health services research and health policy professionals for even greater impact. That's why I'm pleased to share that we will soon be launching a pretty expansive new effort to rethink how health services research can best be conducted and used. Together with experts from our field, many of you in the room, and importantly, experts outside of our field, as well as our trusted partners in healthcare philanthropy, this new initiative is intended to dramatically enhance what matters, the relevance, quality, timeliness, and impact of our research. So stay tuned. And related, with an eye towards greater impact, Academy Health has also just launched a strategic planning effort with our board of directors, your board of directors. And you'll see a prompt in your emails and in your meeting app to contribute to that process by answering a short survey. You're researchers. Give us a good response rate, okay? After all, you are the core of our network of expertise and influence. So in closing, if you've heard me give my annual remarks before, you know that I always issue you with a challenge at the annual research meeting to use this meeting to continually reflect on the current and potential impact of the work you will discover in our breakout sessions and poster presentations, to build new networks, and to think about the policy and implementation issues that you will discuss. Thank you very much.
Thank you, Lisa. Thank you, Sachin. That was great. So as a reminder, we're going to invite questions from the audience. We're going to have a nice conversation now to hear from our current rock stars within HSR. And so the mobile device that you should, or the URL that you should go to on your mobile devices is arm2019.cnf.io. And you can see it right there in the slides. So while Lisa is getting mic'd up, are you ready? Are you mic'd? Excellent. All right. So while we are waiting for the questions to come up from the audience, you can see here that there is a screenshot of what the app looks like, as well as then where you can see the questions, ask the questions, and then actually vote for questions that you like. And if I go one more, then we should have the questions starting to come up. And there are a lot. So before we jump into those, I'm going to take the questions that I wanted to ask. All right. So let's jump in. Sachin, you had really talked about this concept, and actually this is a question for both Sachin and Lisa. You talked about this concept of the policy window, and both of you have really talked about this concept of being able to be in the right place at the right time. But that strikes me a little bit as sort of a passive approach to what it is that we're trying to do, because we ask these questions because we ultimately would like to see improvement. So my question to you is really then, what is the role of researchers and health services researchers in not only just waiting for that policy window, but driving and helping to create that policy window? So,
yeah, I think it's a great question. And one of the, my observations kind of sitting in the halls of HHS for a couple of years was that there were far too few of you actually circulating among those halls. There were a couple of very entrepreneurial researchers. I remember Chuck Seisler from Children's Hospital Boston came in to talk about his research on sleep and its influence on residents. But there were those examples were few and far between. There weren't a ton of you, kind of roaming the halls with your findings. And I think the folks who did take that effort, Mark Fendrick was another one, the folks who actually did that found a very receptive audience. And the interesting thing is actually just understanding what that does. It doesn't necessarily create immediate action, which is what I think we all want, but it plants a seed for a future conversation, because the next time there's a discussion on sleep, or next time there's a discussion on benefit design, the person you're thinking of calling for input into how to design those regulations or design those policies may be that last person who came to talk to you about it. So I think that there is a role for this community to get, I think, trained on what that looks like, because I think the opportunities to accelerate impact are actually pretty remarkable when you do make that effort.
Yeah, Lisa?
And that raises another point about sort of being ready, is you've got to get to know these players in the policy space. And I think too often, in policy schools, the perception is policy is legislators and elected members of Congress and this, the head of HHS. But there's an army of folks who are at career stages and intermediate who are hungry for that evidence, but they want to know you. And they need to know that you're available to give advice, because they rely on their network of trusted professionals to call on. So building that network, again, to my point, not just when you want something, but being available to them when they need something, and being responsive as well as planting those seeds.
Yeah, and another example, that I can reference is, there's been a ton of work in the last couple of years on diabetes prevention and translating a lot of what we know about the science of diabetes prevention into policy models and payment models. All that work got started, kind of in 2009, 2010, as the folks who were doing that research were actually bringing it forward to CMS and NIDDK and creating conversations that weren't happening across the agencies. It wasn't that we weren't a receptive audience and we just didn't know about it. And then I got very passionate about it. I talked to Berwick about it. Then Al Franken called him. Just these things just kind of have this sort of very kind of interesting, unexpected pathway. But it oftentimes just starts with somebody having a conversation and saying, hey, did you know about this evidence that shows that? Which is very powerful.
Yeah.
And the other way research can open that window is, this is the exception, really, but sometimes a landmark finding so takes us by surprise, like Kevin Schulman's study of the bias in care by cardiologists around older Black individuals, particularly older Black women, not being referred for cabbages and more extensive workups. That just hit Washington we all knew that, like the field, we know their biases, we know their disparities, we've been studying it forever, but sometimes that documentation of bias in that profound and direct way, and then the publication of unequal treatment really changed the conversation on disparities and drove policy change. And I think that's a success for the research community.
Yeah. So I want to pull out this question that now has 100 votes, which really asks about, given that reimbursement drives innovation, adoption, and spread, the question is really asking how can we collaborate more with payers? And I think that this is a question not only about working with payers, but it also alludes to, Lisa, the issue that you pointed to, which is the need to collaborate and work with the private sector. So I'll ask you both to comment on this. So if you can actually talk a little bit about it, Sachin.
Yeah, so I think it's an awesome question, and my FOM was on a panel earlier. Right? CareMore is a division of Anthem, and I will say that we need to be having way more conversations about your work. The truth is that just like the caricature I painted of Aman Bhandari not sitting at CMS, not necessarily reading papers and translating, it's the same thing when it comes to within the payers. We oftentimes don't know what we don't know. And so as a result, we're not necessarily, our not acting on your research isn't because we're evil or uninterested in actually implementing your findings into practice. We just don't know about them oftentimes, or we don't know how they necessarily apply in our own context. You have so many answers to questions that we don't even know to be asking, right? That's the honest truth. And so if you can, number one, help inform us what questions we should be asking, and then number two, work with us to actually answer questions, hopefully using our own data. And I think there's opportunities to do that through our health core division, which actually uses Anthem's data and makes it available to research communities. The opportunity for us to then kind of create real world impact is extraordinary. But I think it's important to just map how these organizations work, and I think that they're intimidating because people don't necessarily know how decisions get made, where the power sits, and so people will do one of two things. They'll either start at the top and then try to wait and see if it'll get to the right person, or they'll just call someone that they know, which are both very imperfect methods of actually arriving at the right audience for your work, because you won't often get there. So I would just say, think about mapping, who works at Anthem, United Healthcare, Humana, the larger kind of payers, understanding who, how those places work. And the neat thing about all these organizations is that they are populated by your former colleagues.
Right.
Right. So my FOM, has sat in this room for I don't know how many years. Will Schrank is now CMO at Humana. He sat in this room. He's a professor at Harvard. We recruited him to CMS and CMMI when I was there. I mean, these are people who are very interested and open audiences who understand this language. And so I think it's starting with those folks and taking advantage of those connection points will then enable some of the real-world pragmatic trials that you want to do, and frankly, we'll be receptive to the evidence that you bring forward to them.
Yeah. So Lisa, I'll ask you to answer the same question, but with a particular focus for the junior faculty in the room or the current fellows or students who may be thinking about what is the potential career path and what are the opportunities, including thinking about, obviously, academia, but then also the private sector.
Absolutely. And so, when I was coming up through the ranks, my career was called a non-traditional career because I didn't go, for my fellowship, K, et cetera, et cetera. And I think we talked about this in the Education Council. One of the things we're doing coming out of the Workforce Summit in 2016 is really looking at the range of career trajectories that folks have and the different ways to find really fulfilling work in different settings. And again, the academic statistics I mentioned are part of the reason, but there's just so much opportunity. And so I think that we as the academic portion and our training program directors who are here, I would also say we have to acknowledge that there's sort of a cultural bias that is indoctrinated in too many students, I think, that the only way to do good research or contribute is to be in academics, and those who can't make it go into other settings. And that is just doing all of us a disservice. And we are not fulfilling our responsibility to improve health and healthcare. So I think the ability to make a difference and do fantastic work, it's just different work, is really important. The other thing, to Sachin's point about, our colleagues are in these settings, in health plans, Patrick Conway, all kinds of people. But the thing is, not only are they trying to use the existing evidence base to think about their payment incentives and how they do it and keep up with the latest article on ACOs from Michael, et cetera, the thing we can do better with them is help them design. Maybe they won't go all the way to a pragmatic trial, but maybe they can think about some step wedge design or a difference in differences, because they're innovating all the time out there, and we're missing all these natural experiment opportunities. And I think we've got to offer ourselves up and find better ways to partner to evaluate and keep that learning going.
Yeah. I would also comment that a lot of public or private sector entities are now actually collecting more and more data, and he who has the data has the power. And so for those of us who want to do research in this space, we need to learn how to leverage those data, think about the different methods, and then also within an academic environment, there's an opportunity to really provide a validity because it's an independent observer of those data. But I think that there is a new potential marriage that we can have. So I'm looking at the question here, which has about over 150 votes, and it asks, how do we better communicate trade-offs in policy to an American public and politicians who want benefits without costs? And what I'm actually also reading behind that is the trade-offs and the opportunity to have that discussion around impact. Again, this word that we keep talking about. So I'll kick this to you, Lisa, first.
So a couple of thoughts. I think one of the reasons America does so much of its healthcare through the private sector is because we are fundamentally unable to deal with trade-offs in the political space. It's really hard. And so, however, I think in recent years, as the costs of healthcare have continued to grow, and we have started to shift more and more of those costs directly onto consumers and patients, the demand for not just information on benefits, but also value has been growing, and transparency of that data to inform choices. Now, not all care is choice-driven, right? When you're sick, you just want to go to your local provider. But I think the conversation has changed now compared to 10 years ago. There's much more of a focus on value in both the public and private sector. And even in the PCORI reauthorization conversation, while there's still real concerns about PCORI studying costs, there's a recognition that we have to better understand the trade-offs that patients or health systems are making to implement innovations in care delivery. And so I think I'm, again, optimistic that we're able to do that, but boy, we really don't like to make big policy trade-offs. Sachin?
Yeah, I mean, I think this is one of the most important things that this community can really do. I think if you were to talk to most people, who are in the management of healthcare organizations, they all say that their objective is to lower healthcare costs, but that they want a bigger bigger piece of the smaller pie. And I think that you know, what I think most people don't realize is that, you know, having worked in pharma, having worked in health plans, having worked in government, everybody loves to demonize someone, right? It's a little bit how we're trained. So, and then we instinctively just demonize whoever we're trained to demonize from whatever point that we sit at. So, you know, lots of people love to pick on pharma, and they will point at pharma and say all costs are coming, and then the data doesn't actually say that, right? There's many other kind of sources of cost, you know, pools in our system, and so I think this community can be really powerful and helpful in terms of actually helping to create a more accurate picture for people, because I think this community has actually been guilty at times of creating an inaccurate picture for people by focusing on certain pieces of the pie that may be, you know, less guilty than we think they are. And the right answer is that every part of our healthcare system is complicit in creating the healthcare system that we have. But I'm not sure that most people would say that. I think if you were to ask most Americans why healthcare costs are high, they would point at one stakeholder and say, it's those damn, right? And I think that's what we have to help people move beyond.
So that takes me to the next question, which I'm going to skip to, which is really asking, what is it that researchers can do to rapidly identify the most critical questions that end users want answered? And so, for example, when you think about this issue of cost, we do point at different entities, but we, for example, never look at issues such as waste, which we know is a huge challenge within the healthcare system, and there has been some estimates that it's about 30% of the costs within healthcare are a function of waste, yet we don't necessarily have an agenda around that. So how do you think researchers can really be responsive to ask those right questions in a timely fashion? So
I think it's tying it to a business imperative and tying it to a question that really matters for the organization that you're working with. So at CareMore, you know, we're a fully at-risk provider of healthcare services, and we know that our number one cost item is inpatient admissions. And we want to be able to safely avoid as many inpatient admissions as possible. So I would love to partner with this community to identify, you know, what are the inpatient admissions that we should be avoiding that we're not. You know, I have some sense of that, just based on anecdote, just based on, you know, reviewing the patients that we see on any given, you know, day. But I would love to be able to partner with sophisticated health services researchers to better answer those questions. I mean, I think we tend to, you know, kind of fall back onto sort of these easy answers like, oh, we don't know what anything costs in healthcare, and we have big cost accounting problems. The truth is we know that there are some really, really big cost pools that we can go after today if we just decided to do it. You know, looking at formularies and looking at deprescribing, you know, medicines that are unhelpful to senior patients, helping us think about ways to do it, helping us target what kind of providers we should be going after in terms of helping understand which ones we need to re-educate around deprescribing certain medicines. There's just all kinds of real life questions that, again, I think if you go back to this idea, you have to know how an organization works before you change it. I think if we all invested a little bit more time in understanding, you know, organizations, their business problems, we would be able to make a much bigger impact.
So then could you comment on, frankly, the rub between specificity and generalizability? So if we're looking at your healthcare system, that is a very specific question with huge opportunity for impact if you adopt changes as a result of research. But if I then, as a researcher, also want to get published, it has to be generalizable findings. So can you talk about that?
So I think that many collaborations that should be happening aren't happening because people get stuck on this question. They're like, well, it's just, if it's only interesting to CareMore, then we're not really that interested in studying this problem. But guess what? You know, CareMore is now 25 years old. There's a lot of CareMore copycats out there now. There's other organizations that look and feel and operate like CareMore that are focused on high cost, high need patient populations. There's probably 5 or 6 million patients who are managed under models like ours, and they're only growing, you know, as we speak. And so then the question becomes, you know, how do you answer the question for CareMore in a really specific way? And then how do you embed yourself in the broader narrative of what's actually happening in the healthcare delivery space? And there are a number of organizations that are trying to do what we do, focusing on high-cost, high-need patients. And they're, you know, Jeff Brenner isn't the only one. It's not just hotspotters, right? And so, again, I think it's also just mapping the landscape of players so that you actually realize that the question that we're asking isn't just a specific CareMore question. It's a question of broader interest in an area that's only growing in the industry. And I think, to your point, I think so many people get stuck on, well, that's just one organization. It's not going to be that generalizable. The truth is if we go really deep, we're going to find out some things that I think lots of organizations could learn from.
Yeah.
And to that question about, again, learning the key questions for researchers faster, I think partnerships are essential, whether it's with CareMore or in the policy space, state researchers and state policymakers. And so that's a big part of the Academy Health agenda, has been helping our field to build these kinds of networks. We just also launched the Learning Health Systems Interest Group, again, to try to build up our connections with partners in care delivery. And to your point about publications, Anne, we also just partnered with a journal that Sachin and Amol launched 5 years ago?
I think 7
years ago. The journal called Healthcare, the Journal of Delivery Science and Innovation, because we want to get more of this learning about what it takes to actually transform care. So those are some of the things, but we'd welcome your ideas about how else do we support you in making those partnerships, because that's how you're going to know what the needs are more quickly.
Yeah, I think the New England Journal has kind of recognized that, this with the launch of Catalyst. They're now launching a Catalyst journal. There's I think a recognition that the traditional publishing standards don't necessarily apply to the kind of work that we're talking about, but it's no less important. It's just, they don't fit into the current identities of existing journals. And so that's why there's new journals. And then frankly, the old journals are now saying, wait a minute, our identity isn't necessarily working anymore for the changing world and the needs of the broader landscape. And so I think there are these incredible opportunities now to publish in different formats. And I also think it goes back to this incentives question, which is, when will promotions committees start to recognize when the real world impact isn't going to necessarily be quantifiable in terms of the paper and the Thomson Reuters impact factor, and that it needs to be quantified based on how many patients had their care changed because of an insight that happened. And that's I think a phenomenal measure that we should start to think about when we look at the promotions model of the future.
Yeah.
And I really want to underscore this point about incentives. We talk, whether it's Michael or anybody else, we're all about incentives for providers, incentives for patients. What about our incentives to do the work that we do? And so really grappling with that in terms of every setting in which we work, that's going to be part of this initiative that I alluded to. We're seeing, and we're really trying to learn from other countries as well. You may be familiar with, in the UK, with the Research Excellence Framework, where for a certain pot of money, every 5 years, the institutions have to demonstrate their impact on populations, community, whether it's environmental sciences, humanities, healthcare, et cetera. NSF is trying to move in that direction. The Canadians are doing it. So I think that we have an opportunity to jump in and really say the old models are not good enough. And also, the world around us is changing so fast, and other people are moving into the space and generating knowledge so much quicker, and it's good enough. It's not just the journals who are trying to, figure out what their role is. I think there's a whole change with open data, open access.
So let's riff a little bit on that, because we have some questions here about new methodologies. And so as we know, there's work that's going on in terms of real world evidence, artificial intelligence, et cetera. And it's really a new paradigm in terms of how we take data and the results that we get from it. And are we looking for p-values or, as you said, the good enough kind of outcomes? And then in the real world, where there's a need for wraparound data analyses and we need to know the answers quickly, our traditional methods and waiting for data that are 18 months old just isn't going to cut it anymore.
So we need to work simultaneously on producing this data, but then also teaching people how to use it. I'll just reflect on an embarrassing example from CareMore to make this conversation real. We had a program focused on dementia patients, the results of which we actually presented to staffers on the House Ways and Means Committee, where we looked at an intervention that of patients who were in this dementia program that was really around educating dementia patients about their diagnosis. And we looked at patients who were in the program and we looked at patients who were out of the program. And we saw remarkably that the PMPM costs of in-program patients were much lower than patients out of program. No one had stopped to ask the question, were these patients different? Obviously, if you're a patient with a dementia diagnosis who can make your way into an educational program, you're going to have lower costs than patients who weren't able to make their way into the program. And we were presenting this data externally, and I kind of joined the organization. I said, "What are we doing here? This is kind of insane that we're doing it." And nobody on the House Ways and Means Committee, no one internally, stopped to ask this question, are these folks different? You guys live in this world of methodological rigor and integrity that is, where these things are just second nature to you. But we haven't educated the users of this data on how to actually use it. And so, a lot of these folks were your students in health policy classes and undergraduate courses. They were your students in master's courses. You need to make sure that they know this stuff, guys, because otherwise we're going to make really bad decisions based on not necessarily knowing how to interpret data and simple things, like correlation does not equal causation. And I'm telling you, one of my biggest achievements at CareMore is I feel like the organization gets that now. Because I will ask that question over and over again, like how do we know correlation is actually driving causation? We did X, Y, and Z, but how do we know it's X, Y, and Z that cause Y? That's not how people who work in the very fast-moving world of implementing new programs and management think about things. So I just think we have to work on these parallel tracks.
So we're close to time. So I want to bring us back and just ask you in closing to think about the question that's really today's session is what impact will we have? When you think about healthcare, there are so many people involved. There are providers and payers, lots and lots of lawyers. There are policymakers. There's so many other entities or professions who are involved. And so then the question is when we look at health services research and the community of health services researchers, what is the impact that we can potentially have? So just one nugget, if you think, when you look forward to 2025, what will be the impact of HSR?
I think what success looks like is the executive teams of healthcare delivery organizations and health plans have a chief research officer who's sitting at the table alongside the rest of the executive team, bringing new evidence to the table and asking provocative questions that can actually drive the organization forward. I think that's what 2025 looks like for me.
Lisa?
And I would say that that executive team is populated by a generation of folks who have been trained in not just the core competencies of HSR, the hard stuff, but also the skills, the soft skills as they're called, of how to work in teams, how to be diverse, how to communicate with users, how to do stakeholder engaged research, whether that stakeholder is a patient or a policymaker or a Sachin who's a CEO of a system, a health plan. So we really need to change not just the next generation, but as one comment made, we have to allow those of you who are in the in our academy to also get out of your world and go spend some time in this world and understand it, because the more we understand each other, the more impact we're going to have.
Thank you. Impact. So that concludes. That concludes our session, and as I said earlier, we invite you to come and join us tomorrow at the presidential session where you can hear more from the other rock stars within health services research. Go forth and have a great meeting.